Hello, this is Eric Strong from the Palo Alto VA and Stanford University. This is the 14th lecture on understanding ABGs, and the topic is pearls and pitfalls of acid-base analysis. Specific topics that will be addressed include whether a venous blood gas is an acceptable substitute for an arterial blood gas, whether to use the measured or calculated serum bicarbonate level, what the effect of temperature is on ABG analysis, and what the sensitivity is of the anion gap for detecting elevated serum lactate. In addition to answering these questions, there will also be two examples of frequently misinterpreted ABGs. The first topic to discuss is whether a venous blood gas is an acceptable alternative to an ABG. A couple of studies have attempted to answer this question, which can have substantial practical significance. I'll briefly present two of the most relevant. First is a single-center prospective trial in which all adult patients presenting to the ER with suspected DKA had simultaneous ABGs and VBGs drawn at presentation. Here's a summary of the findings. The average arterial pH was 7.20 and average venous pH was 7.17. Average arterial calculated bicarb was 11 and venous calculated bicarb was 12.8. To eliminate concern that there was still great variance between the arterial and venous gases, here is the arterial pH plotted against venous pH with a best fit line included. As you can see, there was only one outlier, which happened to have occurred at an extremely low pH, where the error of the lab measurements themselves are likely much greater. To address whether this level of agreement held true in a wider variety of patients, a single-center prospective study was published in 2010 in which all adult patients who were admitted to the ICU who otherwise needed both a central venous catheter and an arterial line were enrolled. Whenever an ABG was deemed necessary, a central VBG was also obtained. And here are the findings. The average arterial pH was 7.37 and venous pH was 7.34, the same 0.03 difference as the prior study. The average arterial PCO2 was 38 and venous PCO2 was 42. Here is the arterial pH plotted against venous pH, and you can see excellent agreement for the individual data points. And here is the arterial PCO2 against the venous PCO2. The agreement here is not quite as impressive, but within the range of 30 to 50, it's still fairly good. In case you are wondering about the agreement between central VBGs and peripheral VBGs, this study examined the agreement between those two parameters in a smaller subset of patients and found no difference. In summary, while VBGs provide no information about the oxygenation status of a patient, they can probably substitute for ABGs in most analyses of acid-base status. The arterial pH is approximately equal to the venous pH plus 0.03, and in millimeters of mercury, the arterial PCO2 is approximately equal to the venous PCO2 minus 4. Certainly not all clinicians believe VBGs can substitute for ABGs in analyzing acid-base status. Also, these very simple equations I've listed are just estimates. The last study I cited actually derived more exact equations using multivariate regression, but they are far more cumbersome and provide accuracy that's only minimally improved except at extremes of pH. The next topic is which bicarbonate to use during acid-base analysis. The bicarb measured in serum, which more accurately is a measure of the total carbon dioxide in the blood, or the bicarb calculated from the ABG. To remind you, the ABG analyzer will calculate the serum bicarb using the Henderson-Hasselbalch equation. This is a common question which I've avoided in the past 13 lectures by generally choosing examples where the measured and calculated bicarb levels are nearly identical. Historically, physicians in training have usually been taught that the measured bicarb should be used because it's somehow more accurate by the simple virtue of the fact it's directly measured. I personally think this argument, if you could even call it that, is extremely weak, since the calculation of bicarb from the equation here is in fact based on the actual definition of pH and not some kind of estimate. In other words, using the Henderson-Hasselbalch equation to calculate bicarb is very different than equations used to estimate serum osmolarity or creatinine clearance. I also think that there is a subconscious bias in favor of the measured bicarb because the machine that measures it is much larger and usually located in the hospital's central lab, as opposed to a handheld ABG analyzer at the bedside, which necessarily seems like it's more of a crude device. However, a comparison of one versus the other would certainly depend upon the brand of equipment. The historical practice of disregarding the calculated bicarb also evolved decades ago when the technology in bedside ABG analyzers was not as refined as it currently is. Luckily, in most cases, there is no conundrum in deciding which of the two bicarbs to use. First, in my experience, the ABG and measured serum bicarb are not usually drawn temporally close to one another. For example, in an ER patient, usually the bicarb is drawn by the nurse as soon as the patient is placed in a room, but an ABG is delayed until either the doctor sees the patient or until the doctor sees that the original blood draw is consistent with a major acid-base abnormality. By then, the patient has usually received some form of treatment, rendering the original bicarb level obsolete. So as a general rule, use of a measured serum bicarb in acid-base analysis that was not drawn simultaneous to the ABG can yield erroneous results. The other reason no conundrum exists is that when the two are drawn simultaneously, they are almost always in agreement with one another. In one study, for example, over 17,000 records of simultaneously drawn ABGs and chemistry panels were compared. This chart demonstrates the findings of that comparison. In the left column is the difference between the two samples in millimoles per liter, and in the right column is the number of samples that demonstrated this difference. In other words, 36% of the time, there was no difference between the measured and calculated bicarbs. 46% of the time, there was 1 millimole per liter difference, and so on. As you can see, it was very uncommon for these two values to diverge by more than 3 millimoles per liter, the approximate point at which the difference reaches major clinical relevance. So in summary, the measured and calculated bicarbs are within 3 millimoles per liter of one another almost 99% of the time. If the ABG and venous bicarb are drawn nearly simultaneously, the majority of clinicians believe that the measured venous bicarb is the one that's best to use for acid-base analysis, although this assertion does probably depend on your lab's specific equipment. If the two are not drawn simultaneously, use of the calculated bicarb from the ABG is probably best. If you've ever seen the actual printout from an ABG analyzer, you may have noticed that it usually reports 2 ABGs. Why does the machine do this? This is a consequence of the fact that changes in temperature of blood lead to subtle shifts in the equilibrium that determines the partial pressure of dissolved gases. The higher the temperature, the more gas can be dissolved. The lower the temperature, the less gas can be dissolved. The electrodes in the ABG analyzer are kept at a continuous 37 degrees. Therefore, when an ABG from a person with abnormal body temperature is inserted into the analyzer, the blood will be warmed or cooled, and the reported PO2, PCO2, and thus pH will be different than actual. For example, imagine a patient febrile to 39 degrees Celsius with a pH of 7.37, PCO2 of 44, and PO2 of 91. If an ABG is drawn, when that blood is inserted into the analyzer, it will be cooled to 37 degrees Celsius. At that point, the equilibrium determining the partial pressure of dissolved gases will slightly shift such that less gas is dissolved in the blood. This will result in lower PCO2 and PO2. In this particular example, the pH of the cool blood inside the analyzer will become 7.40, the PCO2 will be 40, and the PO2 of 80. Here's a simple chart demonstrating the degree by which the adjustment can shift the results of ABG analysis for a range of possible body temperatures. For example, if a hypothermic patient with a temperature of 30 degrees has a completely normal ABG when reported by the analyzer, that patient's actual pH is probably about 7.50. Complex algorithms have been developed that are used by the analyzers to correct the reported ABG for the patient's actual temperature. Thus, most analyzers actually report two ABG results. One ABG if the patient's temperature is hypothetically 37 degrees, and that for the patient's actual temperature, which needs to be manually inputted by the analyzer user. You might wonder why the machine doesn't just report the ABG for the actual temperature. In other words, if the patient's temperature is actually 40, who cares what the machine would have reported the ABG to have been had the patient been euthermic? The reason both ABGs are reported is probably related to the fact that we don't actually know what the normal ranges for these values should be in a patient who is not euthermic. For example, if we had a severely hypothermic patient at 30 degrees and we checked an ABG which was, quote, normal if body temperature is normal, as mentioned before, this suggests a true pH of 7.50. This would lead us to the conclusion that the patient has a significant alkalemia that needs to be worked up and explained. However, for all we know, normal pH in a patient who has been cooled to 30 degrees might be 7.50. Therefore, there would be no pathologic process present that was specifically driving the alkalemia and which needed to be identified and treated beyond the hypothermia itself. If you are feeling confused at this point, you are not alone. This is a controversial subject in ABG interpretation and an issue which remains unresolved. Luckily, the adjustments are relatively small and of modest clinical relevance for all but extreme deviations in body temperature. The presence of an elevated lactate level is almost always indicative of anaerobic cellular metabolism, most commonly seen in hypoperfusion complicating shock. The ability to detect elevated lactate is critical for appropriate diagnosis, triage, prognosis, and even treatment of patients in shock. As just one demonstration of the importance of lactate levels, a prospective observational study was published in 2007 in which approximately 1,300 patients with a suspected infection had both their initial systolic blood pressure and serum lactate levels measured and recorded. They were then followed for 28 days to see which patients survived and which didn't. This chart shows their 28-day all-cause mortality rates as a function of both systolic blood pressure and serum lactate. A lactate level less than 2.5 was considered normal. As you can see, at each level of hypotension, an elevated lactate level further increased mortality. In practice, clinicians frequently rely on an elevated anion gap to suggest the presence of an elevated lactate, instead of reflexively checking it on all patients admitted for infection. You might therefore wonder how sensitive and specific an elevated anion gap is for detecting an elevated lactate level, especially if the gap is corrected for low albumin. Here's a summary of 4 trials that attempted to answer that question. As you can see, there was a complete lack of agreement between the 4 papers. As a consequence, the adjusted anion gap may be inadequately sensitive for detecting clinically relevant hyperlactonemia, and therefore serum lactate levels should be directly measured in patients presenting with evidence of severe sepsis and/or hypoperfusion, irrespective of the anion gap. At this point, I'm going to shift the format of this lecture to discuss 2 specific example cases, each of which will demonstrate a particularly tricky diagnostic dilemma. Here's the first case. A 56-year-old woman with severe COPD presents with sudden onset of shortness of breath for 3 hours. Her temperature is 37.2, heart rate 115, blood pressure 112/66, respiratory rate 35, and O2 sat 90% on room air. She is in visible respiratory distress. Her lung sounds are clear. Her pH is 7.50, PCO2 is 48, and Bicarb is 36. Here is her chemistry panel and albumin. So using the general algorithm I've been employing throughout this course, and which was solidified in the last lecture, we'll start with step 1. The pH tells us this woman has an alkalemia. Next, the elevated PCO2 is consistent with a metabolic alkalosis. Next, evaluate compensation. For a metabolic alkalosis, the PCO2 should be approximately equal to 40 plus 0.7 times bicarb minus 24. This holds true, so therefore compensation is appropriate. Next, calculate her anion gap, which in this case is 10. Since her albumin is essentially normal, no adjustment is necessary, so there is no elevation in the anion gap. Thus, we can skip the delta ratio and move right on to generating a differential diagnosis. This is what is interesting about this case. Why in the world would this woman, presenting with sudden respiratory distress, have an isolated metabolic alkalosis? The first clue is to look at her baseline bicarb, and in this case her bicarb 2 weeks ago, when she was feeling at baseline, was also 36. So her elevated bicarb predates her acute illness. If you think about this situation for a moment, the most logical reason a woman with severe COPD would have an elevated bicarb at baseline is that it represents normal metabolic compensation for a chronic respiratory acidosis. So why does our acid-base analysis not detect such a chronic respiratory acidosis? Because it must no longer be present. Essentially, what has happened is that 3 hours ago, some acute process occurred by which her minute ventilation was dramatically increased above baseline, and the remaining high bicarb, which is no longer needed for compensation, is only still there because her kidneys have not yet had the opportunity to pee it out yet. Some people refer to this situation as a post-hypocapnic metabolic alkalosis. I personally don't like this term because it ignores the actual process at work here, which is whatever has caused the patient to suddenly breathe normally when she usually severely hypoventilates. Thus, I think of this as an acute respiratory alkalosis superimposed on a chronic respiratory acidosis. What would cause a patient to suddenly hyperventilate? Any cause of hypoxia could do it. However, first, her degree of hypoxia isn't that great, and second, her chest x-ray shows only her hyperinflated lungs and no other abnormality. The combination of acute respiratory alkalosis and a clear chest x-ray strongly suggests a pulmonary embolism. Thus, we can appreciate how helpful the ABG was in this circumstance. If we only had the history and exam to guide a diagnosis, we would speculate that a COPD exacerbation was most likely, which our ABG has informed us would probably be an erroneous conclusion. For the second and last example, a 5-year-old girl is found incoherent in her basement. Her parents reported that she had gotten into some chemicals. Her vitals in the ER include a temperature of 38.4, heart rate 120, blood pressure 80/52, respiratory rate 8, and O2 sat of 86% on room air. Her pH is 7.21, PCO2 of 70, and bicarb 27. Here are her chemistries and albumin. Step 1, she is acidemic. Step 2, it's a respiratory acidosis. Step 3, evaluate compensation. The story is strongly suggestive of an acute process, so the bicarb should be increased by 1 for every 10 that the PCO2 is above 40. This holds true, so compensation is indeed appropriate. So therefore we're done, right? With appropriate compensation, can't there only be one acid-base disorder? Actually no, but this is a very common mistake. It can be avoided by always checking the anion gap even when compensation looks fine and even when you think you know what's going on with the case. In this specific example, the anion gap is 24. But how could she have an elevated anion gap without a metabolic acidosis? There are a few processes that can cause an elevated gap without acidosis. For example, extreme hyperphosphatemia, that should be considered in this case. But what if we keep going with the acid-base algorithm? So the next step would be to check the delta ratio. Remember, this is the change in adjusted anion gap from normal over the change in bicarb from normal. Here, this will be 12/3, which is 4. If you recall from previous lectures, a significantly elevated delta ratio is consistent with a mix of an elevated anion gap metabolic acidosis and a metabolic alkalosis. So why didn't this show up earlier? It's because the two metabolic processes perfectly balance one another. To refer back to Lecture 7, here is a balance scale that demonstrates how acid-base disorders can balance like this. In this situation, it first looked like we were dealing with an isolated respiratory acidosis that was driving the acidemia. And this is the situation which we are actually probably dealing with, a triple acid-base disorder where two processes cancel each other out, so to speak, with respect to their direct effects on arterial pH. So what is this specific girl's differential diagnosis? Starting with a respiratory acidosis, her history obviously suggests a toxic exposure of some kind. For a comatose child with a suspected toxic exposure, an ethanol level, urine tox screen, and evaluation of the osmolar gap is essential. Her ethanol level is non-detectable and urine tox screen is negative. Her measured serum osmolarity is 295. Remember that her calculated or estimated serum osmolarity is 2 times the sodium plus the BUN divided by 2.8 plus glucose divided by 18. For her, this is 292. Thus, there is no osmolar gap, which helps to narrow down the list of possible poisons. While a normal gap doesn't completely rule these out, it makes less likely methanol, ethylene glycol, isopropyl alcohol, and diethyl ether. For her elevated gap metabolic acidosis, you should start with checking lactate and ketones. In this case, lactate is 5.5 millimoles per liter, and ketones are negative. For the metabolic alkalosis, there isn't a ton of details on this patient to work with, but one could speculate that it was due to vomiting induced by the ingestion. So if I had to summarize the diagnosis for this girl based on the very limited information provided, I would say that she has ingested an unknown toxin resulting in respiratory depression, lactic acidosis, and possible vomiting. Though as suggested earlier, a phosphate level should also be checked to ensure that profound hyperphosphatemia was not leading to a misleadingly high anion gap in the absence of an acidosis. So that concludes this lecture on some pearls and pitfalls of ABG interpretation, and I hope you found these pieces of wisdom interesting and practical. The next lecture will introduce some alternative approaches to acid-base analysis.